Hi, I'm Cathy Ure. I work on evaluating SEEKA, or the Communities in Charge of Alcohol programme at the University of Salford. This is an asset-based community development place-based approach to reducing alcohol harm. This presentation briefly reports on the barriers and facilitators encountered in the initial implementation phase of this programme. Community-based approaches to reducing alcohol harm are needed. SEEKA initially trained volunteers to become alcohol health champions, or AHCs, from pre-identified communities within the 10 local authorities across Greater Manchester. Communities were identified locally as experiencing higher levels of alcohol harm and had population sizes of between 1,600 and 5,000 residents. To participate, volunteers had to live or work in these pre-identified areas. Volunteers completed a 2-day Royal Society of Public Health training programme to develop skills in providing brief advice and to learn about licensing processes. And it was anticipated that they would cascade their training with support to other volunteers. The aim of this study was to identify the barriers and facilitators experienced at local level during the initial implementation phase, and this was identified as the period pre-training to 3 months post-training. In-depth, semi-structured interviews were conducted with 20 stakeholders involved in the implementation, and these included commissioners and local leads of provider services. Interviews were recorded, transcribed and analysed using framework analysis. 8 overarching themes were identified. The first 4 outline external factors, such as the extent of political support. The local context also had an impact, including the availability of existing assets, both formal, such as buildings to meet in, and informal, such as the volunteers themselves, or the presence of any community activists. In some areas, implementation was impacted by the lack of a provider organisation and clear understanding of roles and responsibilities. A further factor was the existing low base of involvement in licensing decision-making at local level, both for volunteers and local leads. It was a new area for all involved. Despite this, SEEKA was welcomed by local licensing leads as an approach that could improve the intelligence received. The next 4 themes focus on factors associated with the recruitment, training, understanding of the AHC role and communication. Due to geographical constraints, recruitment was more challenging than anticipated and described as really hard or really difficult by local leads. Often there were low levels of existing engagement with communities in these pre-identified areas, and social attitudes to alcohol consumption here limited engagement. Different strategies were adopted by different areas, with existing relationships proving fruitful. Some areas struggled initially as the provider was not RSPH accredited, or they did not have access to an accredited RSPH centre, which was needed. The training was described as intense and the idea of cascade training daunting, but considerable energy and enthusiasm was shown in relation to being able to make a difference from a licensing perspective. Once formal training was over, knowing how or where to start with this new role was challenging and included identifying clear boundaries for the AHC role. Many local leads described valuing their alcohol health champions and were committed to developing and supporting them, seeing the role as a stepping stone to build personal confidence. In terms of communication challenges, local leads struggled with how to sell SEEKA quickly and succinctly to potential champions, particularly when operated in a bounded community space. Different ideas of what success for alcohol health champions looked like were also shared, although this was not expressed as a barrier to implementation. So what are the implications of this study? SEEKA is the first exploration of factors affecting the implementation of a place-based alcohol harm intervention, and it offers insight for other place-based community interventions. We found that capacity building is limited by implementation within pre-identified localities, and that SEEKA demonstrates the need to cultivate a partnership-based approach at local level well in advance of implementation to ensure the correct infrastructure is in place and relations are already developed to support recruitment and training. This has been a very brief overview of the experiences of an initial implementation of a complex evaluation, which we will be publishing in due course. More details regarding the AHC approach is reported in the papers and website detailed here. I'd like to acknowledge all of the SEEKA team involved in this evaluation, and also the local leads and commissioners who have provided time and shared their insight in order to aid understanding of place-based approaches to implementing public health initiatives.